Good afternoon and good evening, everyone. I am Sudip Shah. On behalf of Shalina Healthcare, welcome you all for this live webinar on acute cough. Before going to the webinar, we will just have a brief introduction of what is acute cough and all. So, as we know, acute cough is one of the most common condition for which patients seek the medical advice, and it is affecting the general population the most. Despite of being acute in nature, it plays a significant impact on the patient life. As we can see from the statistics, millions of days lost from the school and the work because of the acute cough, and it is responsible for causing billions of dollars spent on the medical care. As per the research, it is said that median time for the recovery is usually 9 to 11 days, and few studies have shown that complete recovery occurs in almost 67% of patients in after 2 weeks and by 80% after 4 weeks. Despite of this, cough is still a challenging problem in the primary healthcare setting. It is usually managed by a symptomatic treatment, and most of the time, combination of phytotherapeutic is used for the management of acute cough. So, this webinar is particularly talking about how to manage acute cough in primary care setting and the role of combination therapy. This webinar is brought to you by Shalina Academy, an educational initiative of Shalina Healthcare. Before we begin the webinar, let's have a brief introduction on Shalina Healthcare. Shalina Healthcare is available is in the African market since last 40 years. We are one of the largest pharmaceutical company in sub-Saharan Africa, and our mission is to provide quality and affordable medicine and make it readily available. We make it readily available by managing our own distribution. There is no middleman involved in that, and we manufacture our product at WHO approved facility. Besides being a pharmaceutical company, we also take part in our social responsibility by participating in lot of deworming campaigns, then patient awareness program, and doing various campaign for the blood detection, anemia detection camp, blood pressure detection camp for the people of Africa. So today's webinar is on management of acute cough in primary setting and the role of combination therapy. To present this webinar, we have a very eminent speaker from India, Dr. DJ Christopher sir. Sir has done his MBBS and DNB from India. Sir is also a fellow of international and the national societies. Currently, sir is a professor of pulmonary medicine at Christian Medical College and Hospital, Vellore, India. Sir is also a chairman of Scientific Advisory Committee, Indian Council of Medical Research and National Institute for Research in TB. Sir is a course director at American Thoracic Society, MECOR India Training Program. Sir is also chairman of Publication Committee of Report, Consortium Indo-US TB Research Collaboration. Sir is also a chair of Research Committee of Indian Chess Society. Sir is a member of Steering Committee of R2D2 Network for Research in Novel TB Diagnostic, UCSF, USA. Sir is also a member of WHO COVID-19 Respiratory Support Working Group and the course director of Diploma in Allergy and Asthma Distance Learning Education Program. Besides this, sir has a lot of achievement during their entire working experience. Sir is listed by Stanford University as among the top 2% scientists of the world. Sir is also a recipient of Lifetime Achievement Award in recognition of excellence in the field of respiratory medicine. Sir has also received CME Excellent Dronacharya Award for the exceptional CME contribution in the pulmonary respiratory medicine. Besides this, sir has contributed significantly in the scientific world, especially in the respiratory, by publishing 242 peer-reviewed articles in the journal. Sir has also published chapters in the 16 books and deliver more than 200 guest lectures. On behalf of Shalina Healthcare and all our audience, I welcome you, sir, for this live webinar on the acute cough. I will just briefly explain the flow of the webinar. After the introduction, I will hand over the session to Dr. DJ Christopher sir. Sir will going to give the details of the today's topic and followed by the audience question answer. Sir, I would like to hand over this session to you, sir. I hope our audience is going to really enjoy this session and they will. It will also help them to improve their practice in the management of acute cough. Over to you, sir.
Thank you, Sandeep. Uh, Good afternoon and good evening to audience in Africa. I have spoken to several international audiences. I have not exclusively spoken to an African audience so far. So I feel privileged this evening and this afternoon to speak to all of you and take up one of the most important practical problems that most of you may face as you manage patients. So let me start by giving you a background of where I come from. I come from a place called Vellore in southern India, which is near Chennai. And our institution is one of the uh, best known institutions in the country. We have about 4,000 bedded referral hospital, and our institute is ranked second after All India Institute of Medical Sciences among all teaching institutions. And among the departments, recently there was a ranking of the private hospital departments, and the Department of Pulmonary Medicine was ranked number one this year. So I work in the Department of Pulmonary Medicine, and it is located in this brand new premises, which we moved into less than 1 year ago. So with that, we'll move on to our topic for today, which is to look at acute cough. So as already alluded to by Dr. Sandeep, acute cough is something that is extremely common. It is unlikely that any of you have not seen it, but not seen it even within the last week. Someone or other must have coughed in the hospital, clinic, or in the community where you work. So acute cough is defined as one lasting for less than 3 weeks. And some important information about cough: it is the most frequent new presenting symptom in a primary care setting. So if you work in a primary care setting, it is likely that you will see more people presenting with cough than any other symptom overall. Now, the commonest cause is viral upper respiratory infection, which is obviously a benign and self-limiting condition in most people. And also, cough is linked to chronic lung diseases like asthma and COPD. The cost of medical consultation and non-prescription treatment is estimated to be 104 million pounds. So a huge cost is incurred in management of acute cough. Now, as already alluded to, almost everyone has experienced cough during their lifetime. If any of you hearing this lecture has not ever coughed, please let me know when you come to the Q&A session. For some reason, women, particularly between the ages of 16 to 64, are twice as likely as men to visit a doctor for upper respiratory tract infection sensitive cough. The seasonality in acute viral upper respiratory tract infection results in a cluster of patients happening during certain season. And at that time also you find the sale of cough medicines go up and hospital admissions go up. Acute respiratory infection is an important reason which brings people to hospital. So hospital admissions also go up. If we compare Asia, Africa, and South America, to the Western data, we find that the prevalence of cough in a healthcare setting, in a hospital setting, is between 10.4 to 13. So, approximately 1 to 1.5 patients uh, in every 10, among 10 patients who are in the hospital, between 1 to 2 patients will have cough. But when you look at people presenting for cough, coming to primarily for cough, you will find about 6.3 to 6.5%, which is little less than the West, which means that about more than 1 in 20 patients coming to hospitals come primarily because they have cough. What are the etiologic or causative factors of cough, and what is the outcome of acute cough? So obviously, respiratory infection is the commonest cause of cough, which is 73 to 91%. So 8 to 9 people presenting with cough, acute cough, actually have respiratory infection. So the median time to recovery is about 10 days, you can say. So some may be more than 10 days, some may be 2 weeks, 2.5 weeks, where others may be 5 days. Complete recovery was reported in 67% after 2 weeks, 79% after 4 weeks, and 21 to 35% patients came back subsequently for some reason. For example, the symptoms did not resolve as they expected. And around 1% were hospitalized and none died. So overall, it doesn't sound very nasty. It doesn't sound like we saw in COVID. So about 1% only may need hospitalization, and it is likely that these people may be elderly, may be immunosuppressed patients, or patients with a lot of comorbidities. And nobody died. That's also very good. So in a primary care setting, which I believe most of you are part of, how do you approach cough? The first step is to take a good history about the symptom of cough, when it comes, how severe it is, whether it affects their sleep, whether they bring up any phlegm, whether they cough up any blood, and what's the color of the sputum, what is the quantity of sputum, does it have a foul smell? All these factors may contribute to us making a reasonable diagnosis. Now, acute cough is self limiting, but we cannot ignore it since it also can be the first sign of something serious. Let's look at some of the serious conditions that present with cough. Neoplasm, which is like lung cancer, presents with cough. And serious infections like tuberculosis, foreign body inhalation, a child or an adult elderly person, something in the mouth, they inhale it. They may have forgotten about it or may not even have realized it. Then they may be coughing. Allergic, acute allergic reaction, what we call anaphylaxis, which is a life-threatening allergy. Interstitial lung disease, a chronic lung disease which causes fibrosis in the lung. So all these may present themselves with cough. That is why we cannot dismiss everything as, uh, oh, it's just cough. Let's not worry about it. And there are certain situations where chest X-ray is required as part of evaluation, which means in most people it is not required. But in certain situations it is required. And what are those situations? So symptoms associated, the following symptoms, if they are there, then you would take an X-ray. If somebody coughs up blood, you have to take an X-ray to rule out things like tuberculosis, lung cancer. If someone has fever, Uh, well, I would say high fever and probably one of the other things as well, then probably it's good to, or it goes on for, let's say, more than a week or so, then we need to take an X-ray. Weight loss. Typically, the acute uh, cold or acute viral infection doesn't present with weight loss, but if somebody has lost weight, that is important. Breathlessness. Now, normally, the infection is largely confined to the upper respiratory tract, and therefore people don't get breathless. But if they do get breathless, then perhaps we need to take an X-ray. Chest pain. Now, there is muscular chest pain due to coughing. That is all right. But if they have any other chest pain, a pain, for example, a pain that increases with breathing, or any other kind of pain which is not attributable to the muscles of the chest because they have been coughing, should alert someone to do a chest X-ray. And then examination of patient gives a lot of clues to diagnosis, and some of them are when you examine the nasal in the nose, the nostrils, or the throat, you may find secretions. Sometimes they are yellow and purulent. So, what does this indicate? This indicates that there is a rhinitis, that is inflammation of the nostrils, pharyngitis, inflammation of the pharynx. And these are typical features of common cold or viral respiratory infections. Examine the ears, particularly if they have ear pain or ear discharge, and then you might find features of otitis, which is ear infection. Then, on examination of the chest, if there is dullness on percussion, bronchial breath sounds, or crackles on auscultation, then these could indicate pneumonia. So, these are some of the examination findings that may prompt further evaluation. So, all of these may prompt more evaluation as required by the physician. In particular, we have to divide the cough that comes into what is life threatening and what is not life threatening. So, let's first look at what is life threatening, and we should be very cautious to pick them up. Pneumonia. So, that cannot be confidently managed in the primary care. So, it is best to see a physician who has investigative facility. Severe exacerbations of asthma and COPD. There are exacerbations of asthma and COPD which are not severe and can be managed at the primary care setting, at home, at the outpatient setting. But if they have severe exacerbation, they need to be seeing a physician, a specialist at times. Pulmonary embolism, a clot that forms in the calf, usually in the legs, and floats up in the veins and goes up to the lungs and promptly is pumped into the lungs, and there it blocks the blood supply to parts of the lung. So that is pulmonary embolism, and that's a serious problem. The patient needs to be in hospital. Heart failure or other serious disease. So if any of these is present, then these people need to be immediately attended to in a center with expert help. But for others, what are the other situations? If they have infections like upper respiratory tract infection or lower respiratory tract infection, which doesn't appear like a pneumonia, exacerbation of pre-existing conditions like asthma, COPD, bronchiectasis, upper airway cough syndrome. So all these, if they are not severe, if they're severe, they come here. But if they are not severe, they can be managed in the primary care setting. Again, environmental and occupational factors like exposure to certain allergens, certain irritants, these obviously are not life threatening, and the management really is keeping people away from these exposures. Now, let me also give a disclaimer that most of what we are discussing has to do with adults, and this algorithm is for adults more than 15 years of age. When do we refer to specialist? American College of Chest Physician lists the following as red flags. Hemoptysis, when someone coughs blood, prominent dyspnea. So not somebody who's slightly little, I feel a little difficult to breathe, but someone who is short of breath. Symptoms such as weight loss, fever, sore throat, hoarseness of voice. That may mean that the nerves going to the voice box or the vocal cords are weak or are paralyzed, and this needs expert help, someone to diagnose it and then look for cause for this. History suggestive of tuberculosis, someone with fever, night sweats, weight loss, and of course coughing up sputum. So this could be, and particular suspicion should be focused on people who have history of contact with cases of TB. Immunosuppressive states. If someone is coughing and they have an immunosuppressive disease or immunosuppressive medications like steroids and other medications, then when they develop cough, they could have more severe infection lurking inside. So they have to get expert help. Smokers cough, especially those who have smoked more than 35 years, in patients older than 35 years. So the older people who are smokers, then because there is a risk of it being lung cancer. Now, some of the approaches would be that if there is hemoptysis or foreign body aspiration, the specialist may do something called bronchoscopy, which is passing a tube through the nose or the mouth and looking into the airways of the lungs and inspecting and finding a cause for the coughing up blood or finding a foreign body. If they have voice change, they could have vocal cord palsy, and that requires a ENT evaluation to see the vocal cord movements and make a diagnosis. When acute cough is accompanied by significant breathlessness, of course, it could be asthma or even anaphylaxis. So, when anaphylaxis is suspected, anaphylaxis is a severe allergic reaction, we would ask for history about uh, ingestion or contact with certain allergens. For example, ingestion of prawn, uh, or let's say a bee sting, wasp sting. All these are likely causes of anaphylaxis, or certain drugs that are known to cause anaphylaxis. Then acute cough with fever, extreme fatigue and purulent sputum, coughing up yellow or greenish sputum, means they have a acute lung infection. Now, I have to talk about the most important player in this, which is seasonal flu. All of us are familiar with this. Seasonal flu is an acute respiratory infection caused by influenza virus, which circulates obviously in all parts of the world, but different strains circulate at different times in different parts of the world. Now, among the influenza viruses, influenza A and B viruses circulate and they cause seasonal epidemics of influenza. The symptoms are sudden onset of fever, cough usually dry, headache, sore throat, running nose, muscle joint pain, and feeling unwell. And the cough can, may at times last for 2 or more weeks. So the fact that it lasts for more than a week doesn't mean that it is not influenza and it is something else. Now, the good thing is it is mostly mild and self limiting, and except in elderly and immunosuppressed, where it is likely to cause severe disease. So, this is seasonal influenza. We may encounter it very frequently, but we need to be careful, especially when it affects elderly and the immunosuppressed. Maybe, sorry, going backwards. Now, I want to give you some statistics. Every adult an average has 2 to 4 colds per year. So it is as common as that. And children may have up to 10 colds per year. And invariably, children bring cold from the schools and from other children and spread it to the elderly people at home, their parents and grandparents. The problem is particularly more when they spread it to their grandparents. How does it spread? It is very contagious. It spreads from person to person. It has to come out through secretions. Either it is the secretion drops or forms droplets. Droplets are very fine microscopic particles that are thrown in the air when we cough, sneeze, or even speak loudly. And these can be inhaled by others. Now, contact with nasal secretions, so they may blow their nose, then they touch the table, somebody else touches the table, and then puts the hand in their nostril or eye or somewhere, then it goes into their system. It is particularly contagious in the first 3 days of symptoms, and the viruses can last up to 5 hours on skin and on hard surfaces. So even if somebody sneezes, goes away, and then somebody comes back, sits there, touches, and goes, they can still get uh, influenza. How do we prevent? This is very important. We all live in community, and in our communities, the first responsibility is ensure that we prevent the spread of these infections. We reiterated this multiple times in the context of COVID-19, which all of us, I'm sure all of you, encountered in your countries, and we encountered it big time. And the second wave of COVID caused a lot of morbidity and mortality. And of course, when we talk about influenza, we also need to remember the COVID. COVID, in fact, is in many ways like influenza. But this COVID-19 had a lot more people going into the hospital. There were a lot of people with mild illness like influenza, but a lot more people went into hospitals, and of course, people also died. So, covering the cough. So, in any public place, anybody, when they cough, they have to cover their nostril and their mouth. Wash the hands with soap multiple times. It is inevitable that you will touch secretions. So, frequent washing of hands, and avoid touching eyes, nose, and mouth with unwashed hands. This is in order not to develop. And stay away from people who have influenza or influenza like symptoms. How do we manage common cold? Of course, many people manage this at their homes. So, what do we advise? We advise them rest, drink a lot of fluids, uh, breathe nice humidified air, and if the nose is stuffy, use some saline nasal rinses. If the throat is sore, use saline goggles. And if required, and if the cough is bothersome, use cough syrups. So these are all the advice we give to people. Now, let us move on from this to specific advice about management of cough with medications. Obviously, this should be reserved for people with acute bothersome cough. Everybody who is coughing, however mild it is, do not need treatment. But if the cough is bothersome, they need treatment. So it is a symptomatic treatment that we are giving. We are not particularly attacking the disease with antivirals or things like that. We are just giving medication that make people feel better as they heal on their own. How do they heal from influenza or upper respiratory tract infection? They heal on their own. The viruses will pass off by themselves. The body will overcome them. We can use antitussive agents for those with dry cough. And since the dry cough doesn't bring out anything, it is okay to suppress it. But if they are bringing out secretions, we would not like to suppress it. The secretions getting trapped inside is not a good thing. So we may give expectorants which facilitate the secretions coming out. mucolytic agents which loosen the secretions and make it easy for people to cough out. So some examples of antitussive agents, one is dextromethorphan, which can be used for dry cough. Expectorants and mucolytics include guaifenesin, ammonium chloride, bromhexin, sodium citrate, and these should be used for the wet coughs. So, as I've already told you this, now let's look at the antitussives or the drugs that suppress the cough. So, as I said earlier, this should be used only for dry cough. We should not be suppressing cough in people with in people who are bringing up secretions. So the pathway for this is there are two types. There are centrally acting antitussives. They suppress the cough center. Now remember, cough is triggered off from the brain at the central cough receptors. And there are peripherally acting ones that do not work in the central nervous system. The centrally acting ones are codeine, phylocodeine, and these methadone, morphine. So these are all narcotics, whereas dextromethorphan is not a narcotic and therefore may be a good agent among these. And peripherally acting agents, levodropropizine or dropropizine. So these are all peripherally acting agents, and of course they are also very attractive options. Now, how do we treat wet cough? For wet cough, as we said earlier, we have to use expectorants such as guaifenesin. They, as I said, they help to loosen the secretions and enable the secretions therefore to be more easily coughed out. And often it is combined with an antitussive. Then, so when the acute cough, which is productive due to infections, usually productive cough is invariably due to infections. That is why also we want the infected cough to be, the infected phlegm to be coughed up. So these drugs which act on mucociliary clearance and move the secretions up are also important. Now, an important point is that we do not give antibiotics for people with wet cough. So invariably there's a reflex reaction. Okay, you're coughing with sputum. All right, take this course of antibiotic. That's not required. Now we have to remember antibiotics are useful only when there is a bacterial infection. They are not useful for allergic cough. They are not useful for viral infections. They are useful only for bacterial infections. So we should reserve antibiotics only for that situation. Okay, now let's look at, in a more practical sense, there are several over-the-counter medications. So most of them contain dextromethorphan at a dose of 60 milligram. It suppresses cough reflex, and I told you it is not a narcotic, and so it can be taken with less fear than when you take the narcotic based cough suppressants. Menthol also is a constituent of these things. It reduces cough reflex and therefore it suppresses cough. It works quite well, but its action is transient. Then sedative antihistamines. Now, antihistamines are particularly used when the symptoms include nasal stuffiness and nasal secretions, and it is useful in that setting. And so, in that setting, it may help along with the other components. The problem with these sedating antihistamines is that they sedate, as the name betrays. So, well, for nocturnal cough, it is all right. You can give a dose and then they can go to sleep. But if they take a dose and go to work, it's not good. So this is something we need to keep in mind. So, as already said, antibiotics should be reserved only for patients with purulent sputum, yellow or greenish sputum, which may indicate a bacterial infection. They are ineffective in reducing duration or relieving symptoms due to common cold. Remember that. And of course, the antibiotics are chosen based on the pathogens that cause infection in that area. Now, the spectrum of bacteria that cause infection is different in Africa as it is in India. We have some very nasty bugs, I can tell you that. Now, even in Africa, you are many countries, and surely in different countries, the pattern of pathogens and their drug sensitivity may be different. In fact, even within the same country, you may have difference. So, it is important to be aware of the germs that are prevalent in your area and their susceptibility to the antibiotics. Now, another component that frequently gets used in acute cough is bronchodilators. Now, they are helpful when there is concurrent asthma. Remember, bronchodilators work when there is bronchial constriction. So, if patients have asthma in the background and then they develop acute cough with or without fever and other symptoms, among other medications for cold, they should also receive bronchodilator medications, which will give them symptom relief. And very important to check if they are taking their chronic asthma medications regularly. Many patients, when they feel well, stop their asthma medications. And these acute infections will trigger an exacerbation of asthma. So it's important at that time not to just give short acting salbutamol like drugs, but also ensure that they are on their long acting chronic medications. Now, often the remedies for cough are combination of agents. They are usually combinations of antitussives, such as antitussives in combination with uh, which have combinations of dextromethorphans or codeine, which are uh, cough suppressants, with antihistamines, expectorants, decongestants, and even antipyretics, which have effect on fever. So a lot of these combinations are there. I personally think that the less number of drugs there are there, the more you have control over things. So several antihistaminic and opioid derivatives are available in the market. And although the later generation antihistamines are non-sedating and are used for allergic rhinitis and other chronic allergies, when people have nasal secretions and cough, perhaps the older generation antihistamines work quite well, like chlorpheniramine, diphenhydramine, and so on, in combination with the cough suppressant drugs like codeine and dextromethorphan. Okay, so as already said, the first generations are better decongestants than the more recent antihistamines. So often the first generation antihistamines are used with the antitussive agents. Okay. Now, again, we'll go back to the focusing on components. I want to reiterate that bronchodilators are given when there is background history of bronchial asthma, either diagnosed earlier or at present, the patient's history suggests an asthma background. So then you have to combine the classical cough medicines with bronchodilating medicines. And bronchodilators are best given in the inhaled route. So that also should be kept in mind. Okay. Now, remember, we said earlier that cough is treated when it bothers the patient. It's going to last only for 7 or 10 or at the most 2 weeks. So we don't have to go at it with hammer and tongs. But when it starts bothering patients, then we have to treat it. Now, antidepressives with central mechanism of actions like opioids may have some sedation and they have the risk of opioid side effects, whereas dextromethorphan is in that sense more safe. And the peripherally acting antidepressives, which is levodopa, are very attractive and they are very good with dry cough, as is dextromethorphan. Okay, so I want to spend some time going through responding to your questions, which you may have. But I wanted to share this important patient information leaflet. It's good if all of you have copies of these to give to your patients. So I will go through this because all these points are important for us to understand the disease and advise the patients appropriately. You got a cough. The most short-term coughs are due to virus infections. Antibiotics won't help even if you're bringing up phlegm. And you probably don't need to see a doctor. So many of you are non-doctor healthcare workers, and so which means you may be able to manage many of these patients. You will probably feel tired with running nose, blocked nose, and perhaps mild fever and aching bones. We recommend a home remedy such as honey and lemon if you feel the need for treatment. Of course, if the patient is benefiting from it, don't force home remedies that don't help the patient. You can be treated from a pharmacist with various cough remedies that contain dextromethorphan that may be effective for dry cough. For wet cough, expectorants and mucolytics will help. Take some paracetamol. I would add here that if you have fever or body pain, menthol lozenges or vapor might help too. Stop making it worse. How do you stop making it worse? If you are a smoker, by stop smoking. Remember, coughs and sneezes do spread disease. Try not to affect others. Use handkerchief and don't forget to wash your hands. You should see your doctor if you cough up blood, if you are breathless, if you have prolonged fever and are unwell. You have medical conditions such as chronic bronchitis, heart disease, asthma. You have recently been in hospital, or your symptoms persist for more than 3 weeks. So these are all apt instructions for your information and also for the patient. In conclusion, acute cough is the most frequent new presentation in primary care settings. So you'll be seeing a lot of patients with acute cough. A good history and physical examination of the patient is essential. The warning signs must be taken care of, and you should refer patients appropriately to specialists. Acute cough may be largely self limiting, so you may need just to encourage and support patients. But when cough is bothersome, treatment may be based on the diagnosis of whether it's a wet or a dry cough. Single agents may or may not be effective, so combination agents are usually the ones that are available in the market that may be used as required. And treatment of wet cough uses a combination of mucolytics and expectorants, whereas dry cough uses dextromethorphan, levodopa, and levocloperazine. These are very effective cough suppressants. SABA or bronchodilators are used when there's a background of asthma. Even if there's a suspicion of asthma, I think it is okay to use it. But it should not be used for everybody. I think with that, I will end my lecture. thank you for your patience. And if you have any questions, and I'm sure you may have uh, already posted your questions, we'll answer them.
Wow. Thank you, sir. It was such a wonderful presentation. I like the way it was presented, means covering the basics of the acute cough, then the diagnosis and the treatment part. I especially like the part where when to refer to the specialist, because our major audience is primary care physician or the primary care healthcare practitioner who really need to know when they can refer this patient to the specialist. So it was really a nice presentation, sir. Please allow me to take few questions which are not covered during the presentation. So I will go one by one. Okay, so how to manage acute cough in the pregnant woman? That was one question.
Yeah. So, good question. And I have to myself figure it out because we don't think of these things often. But this can happen frequently since cough is a very frequent, acute cough is a frequent symptom. It certainly can come for pregnant women. The good thing is that it is usually due to self limiting illnesses like uh, viral infections, influenza. And so we don't need to do anything except support the pregnant woman, give her symptomatic treatments, home remedies, make sure she drinks enough fluid, make sure she takes enough rest, make sure she doesn't have any red flags.
Okay.
And once we attend to all these things, in most situations, we may not need to do anything more. Now, if the patient has red flags, she has to go to a specialist. She being pregnant is more reason why she should go to specialists.
Okay.
Now, if uh, otherwise, I think we should be able to manage them well with good symptomatic treatment. Especially in the first trimester, you may not like to give these narcotics and other drugs uh, for uh, for the cough. So it may be good to use saline in the nostrils. Saline is available as nasal drops and nasal spray. It can liquefy thick secretions and therefore clear it and make people feel better. Uh, Gargling the throat is very soothing to the throat, so that also can be used. So I would use all these modes first and uh, be very cautious about red flags and in that case quick referrals, and avoid narcotics and other drugs, the effect of which on the fetus is not known.
Okay. Right. Thank you, sir. I will move on to the next question. So, so what are the recommended days for taking the cough syrup? Means how long they can one can take the cough syrup? Since the cough duration is between 2 weeks to 4 weeks, so how long they can continue?
So obviously we are using cough syrup to take care of bothersome cough. As
Right.
long as the cough is bothersome, they can take the cough syrup. They need not take it till the last cough is uh, walks out of their life. They need to take it when it is bothersome. When it is not bothersome and things are getting well, they can stop it.
Okay. So there is no such fixed duration for taking the cough syrup. They can take as and when during that period of time they can take it.
Correct. So we have to understand that this is supportive treatment or symptomatic treatment. Now,
Correct.
it is not curative. It is not like an antibiotic which cures the disease. It is alleviating their symptoms and making it more tolerable for them. So,
Okay.
as long as it helps, they need that to be tolerable and their quality of life to be unaffected, they should take it. And then when things are okay, they should stop it.
Okay. So next question is related to the children. Usually, most of the cough syrup they are given in children above 6 years. So how to manage cough in children below 6 years?
Now, I particularly didn't speak about children because children are a different thing. I'm an adult pulmonologist, but I'll
Okay.
give you some simple answers. Now, in children, particularly young children, these things are not recommended or advised or cleared as safe to use.
Okay.
So, we should not jump into using these preparations. So, it is good to address the cause of the symptom. For example, many children may have asthma flaring up and they don't need cough syrup, they need bronchodilators.
Okay.
So that they should be treated for that. So depend, and of course they also need, they can also receive all other supportive treatment, good hydration, and nasal drops when nasal block is a symptom. Children can get terribly affected by blocked nose. So
Okay.
using nasal drops, locally acting preparations which clear as required is a good thing. So really use more conservative methods when drugs are not permitted or not recommended in a particular age group.
Okay. So my next question is talking about this how we can differentiate between bacterial or the viral infection during the management of acute cough.
Good question. Now, in the primary care setting, in a general practice or in a health worker is dealing with a patient, when ask about symptoms, ask about cough and sputum production.
Okay.
So, do they produce sputum? Then, if they produce sputum, ask them the color of sputum. Bacterial infections are usually produce yellow or green colored sputum. So, in the absence of uh, tests and investigations and having to make a decision based on symptoms alone, I think using sputum color is maybe a reasonable method to identify bacterial infection. So, if they have fever, they are bringing up purulent sputum, then they can be given a course of antibiotic. If they are not responding to that or they get worse, then they need specialist help.
Okay.
Okay.
Right. Okay. My next question is it okay to give cough suppression to neonates which has wet cough?
Neonates.
Yeah, which has wet cough.
No, no, it may not be recommended in neonates in either whatever situation. And typically when there is wet cough, then there is secretions which are inside the lungs. And in that situation, the cough is actually there to bring it out. The body is coughing to clear the secretions. Now, if we go and suppress it, we will lock up those secretions. And, locked up secretions cause blockade to breathing and oxygenation. So,
Okay.
patients can get worse or more symptomatic or more sick when these secretions do not come out. So
Okay.
we would not give cough suppressant for someone who has got a wet cough.
Okay. So is there any specific duration which decide the use of antibiotic in the management of cough?
I wouldn't say so, but typically patients may come between 3 to 10 days for
Okay.
with symptoms. By the time it is serious enough for them to come to us, it will be that duration. I mean, obviously they won't come the day they start coughing.
Okay.
And also another thing to bear in mind is that they may have started with symptoms like a viral infection. They may have started with fever, body pain, cold, nose block. Then they have dry cough, and then they may have started to bring up sputum, and then they find the sputum is starting to get colored.
Okay.
So, viral infections can transition to bacterial infections. So that
Okay.
may happen maybe 1 week later, 5 days later, or 10 days later. They had initially got a viral infection, but then there's a super infection with bacteria that is very well known. The viruses prime the respiratory passage for bacteria to come and infect.
Okay. Right. Move on to the last question. It is actually a case where the age of the patient is 4 year, who has on and off cough. It was not so serious, but it was not treated with the use of cough syrup. However, the same patient was given prednisolone once, and she doesn't cough as much. The patient history shows that her mother is asthmatic. So, is there any chance that children is also having a childhood asthma, or is there is just a normal cough?
A high chance. So this is a typical history of a child who may have asthma.
Okay,
The symptoms are that the mother is asthmatic, so there is a family history, and then the child has recurrent symptoms. So,
okay,
recurrent respiratory symptoms, particularly recurrent cough or recurrent wheeze, is typically asthma. And so, the child seems to have all these features. And the third point you mentioned is again very clinching. With steroids, the patient is better. Now, you should not, I mean, I don't recommend that uh, for patients. You shouldn't just be giving steroids to find out, see what happens. Steroids
okay,
should be given only after you diagnose a condition that is steroid responsive.
okay,
A diagnosis of asthma should have been made before giving steroids. But
okay,
now that steroids were given and it responded, it somewhat corroborates a diagnosis of asthma. Now that
right,
the chance of asthma is likely, so go to a specialist and get this diagnosed. And if this child is asthmatic, then this child needs inhaled medications
okay,
and not prednisolone. Child will benefit from inhaled corticosteroids, which is 100 folds safer than prednisolone.
okay,
Okay.
right. So, I would like to thank you, sir, for your enlightening session on acute cough management in primary setting. Along with that, I would also like to thank our lovely audience who are being constantly participating in our online webinars on different topics. Besides that, I would also like to thank our accrediting bodies who has given CMA or CPD points for this webinar. And last but not the least, I would like to thank DocMode for facilitating this session. So with this, uh, I would like to thank everyone for participating in this webinar. Thank you so much.